Good morning, everybody. This is like the last, hey, it's good to see you guys. The last day of SAEM, and this is actually a bigger crowd than I anticipated, right?
Yeah,
This is
pretty much. I
wonderful.
thought it was just going to be us.
So, welcome. This is MTIDE-sponsored HIV hepatitis C screening in the ED. This is an ED conference. A primer, operational primer, is what we're talking about today. So, Jason Haukoos from Denver. I'm going to let these guys introduce themselves real quick.
Oh, my name's Karen Farrier. I'm on University Hospital's Cleveland Medical Center.
Philip Michella, one of the emergency medicine physicians and assistant research director for Prisma Health in Greenville, South Carolina.
And that's thus with disclosures. So the objectives of the session are fourfold: to describe HIV Hep C care continuum rationale for screening and available screening models. We'll start off by saying that this is probably certainly not all inclusive, but gives, I think, a nice primer to what some work is being done out there. Second one is to outline the planning steps necessary for starting an ED HIV Hep C screening program, including applications for integration into ED workflow, and in particular going to focus towards the end on EHR builds. Excuse me. Number three, integrate the use of electronic medical record systems into ED initiatives, and it's analogous to this because we're living in an era where that's like critical to how we do this work. Very different than how we did it 20 years ago. And then implement ED/HIV hepatitis C screening initiatives in their home ED. So just how to bring sort of a practical approach to implementation of these types of important screening initiatives into EDs. So years ago, I had a slide that was the top panel here, right? Do you remember this, Doug? Yeah, right? You have it? Do you have a big one like above your bed? No? Or is it on the ceiling? Hold on a second. You lay in like nine and a half minutes. So back in the day, the incidence infection was about one new infection every 9.5 minutes. And I used to say this, like, right, in the time I'm going to talk today, this is very distracting, by the way, guys. No. In the time I'm going to talk today, there would be a new infection, right? So that number has actually shifted. It's now 1 in every 15 minutes. So we've actually had some inroads. You know, public health broadly in the U.S., we've had some nice inroads, but we're not there yet, right? And we still see 40,000 or so, 35,000 new infections for HIV every year. These numbers are small compared to hepatitis C, frankly. We'll talk more about that in a second. The other thing that's really critical to understanding ED-based like infectious diseases screening, and in particular HIV and hepatitis C, is this number, right? And I think we all know what this number represents. It represents the number of ED visits in the U.S. every year. Right, 150 million, and I also always used to sort of try to get my head around that number and think about if we could do broad-based screening for HIV and now more recently hepatitis C, like in EDs, if we could make this scalable, right, and make this fully integrated across the country, like we'd find infections like that. It'd just be poof, right, in a year or two, and we'd have them all. Incredible challenges around that, and that's what we're going to talk about a little bit today. But this is really the crux of it. It's the intersection between emergency care and patients who present to the ED, the 150 million visits annually, and the fact that they're vulnerable and that they're at high risk or increased risk, and they don't have otherwise access to other forms of medical care where they can actually be tested for HIV or hepatitis C. So the care continuum. This is one of the pieces that we focus on quite a bit. And it starts with diagnosis. A lot of us, and many of us in this room who do this work, have focused on that first piece to the care continuum. But there's multiple downstream pieces to the continuum, right? Linkage to care after you make the diagnosis, right? Another critical step. Initiation of care, starting antiretrovirals, and then ultimately the target status is viral suppression, right? And this, incidentally, holds true to hepatitis C. I'll share that with you in a second. This is the care continuum from a few years ago in the U.S. You can see here we still have a ways to go. 14% of those living with HIV are undiagnosed. That's the left side bar. And then it steps down from there in terms of linkage to care, initiation of treatment, and so forth. This is the comparable cascade for hepatitis C, right? And if you look at the sheer numbers, it's pretty astounding, right? Hepatitis C is magnitude orders higher than HIV in terms of prevalence, in terms of incidence, mostly driven by the injection drug use and the opioid epidemic currently. But what you can see here is that we have a long ways to go, long ways to go. And then I'll share this slide with you. This is something that we published in an editorial when we editorialized one of Rich Shang's papers a number of years ago that looked at the actual HIV care cascade out of patients who are specifically identified in the ED. And what I'll tell you is that the cascade looks similar, sort of the grade bars, right, from time of diagnosis all the way through viral suppression. But the pieces that we highlighted in this editorial were sort of A and B, right? And this is really largely when it comes to screening in ED where we have the opportunity to have the largest impact, right? We need to fill that gap, fill that A gap. It has downstream consequences, as you can see. And we need to fill the B gap, which also has downstream consequences. If we identify these patients in the ED and we successfully link them to care, then theoretically the rest will fall into place. But this is the why. This is why we do it. So I'm going to stop there, hand over this very elaborate slide to Kieran to take over.
Thank you so much. Like I said, my name is Kieran Fryer. I'm from University Hospitals, Cleveland Medical Center. As another plug for MTIDE, one of the things that we did was when COVID started and everybody was looking at screening and testing for COVID, most of the people in the front row who were very much involved in the initial HIV and hepatitis screening really identified that there were a lot of parallels between really all the infectious diseases in terms of screening and testing and linkage to care. So as a interest group, we wrote a paper that talked about those parallel infectious diseases and pandemics and epidemics, and we kind of conceptualized it through this kind of model where you've got the emergency department, here in the middle, and these are all, we won't read them off, but these are all the things to consider for any, insert infectious disease, right? The green circle is things that you need to think about within your hospital or kind of health system. The gray bar at the top is, again, hospital, health system, and also very much including your public health entities into this equation. What are you doing on the far right? So you're testing for something, and we'll kind of go into some details about this. And then the implementation, how are you going to test them? How are you going to screen them? And on the individual behavior level, and again, we saw this a lot with COVID and for sure for HIV and hepatitis, those behavioral change interventions, do patients feel like they need to be tested? How do you get rid of the stigma, which, fortunately, a lot of we came a really long way from the 1970s, 80s to now, but then seeing it all over again with COVID and then again, insert the new future infectious disease in there. As far as testing and the scope of testing, this group did a lot of really good work in really defining this spectrum. So everything from on the far right, your non-targeted universal testing. So it's not I'm coming in with symptoms, but we just want to test everybody. To on the far left, no testing, or just one step above that would be your diagnostic testing. The patient who comes in immunocompromised with thrush and lymphadenopathy, those are the patients that you would initially be testing, as an example for HIV. And then this bar, this last kind of block here is really the nitty gritty of like how to operationalize this. And, this is, again, a model of things to think about when you are starting an HIV or hepatitis program. You don't necessarily need to check off every single box, but you will likely be asked to think about and address them at some point during the program. So just to, again, kind of cover a few of the highlights. So as an example for test assays, I think the word, rapid gets thrown around a lot, but that comes in a lot of different forms. It can be, just geographically, it can be performed in the emergency department, but not necessarily by the ED specific lab. It can be in a wet lab. We had, when I previously worked at University of Cincinnati, we had a little wet lab right next to the EMS room that our staff would go in, they would do a finger stick HIV test and run the test there and have the results within 20, 30 minutes. Are you sending it to your ED specific lab or your hospital lab to be run? So the advantage is obviously short turnaround time, immediate result notification, but you do lose some of the sensitivity and specificity because you're not able to detect those early infections. And then you've got your antigen tests and your antibody tests. Again, these are all things that we heard about a lot with COVID, right? So with your antigen tests, you are able to detect most infections. Again, it's usually pretty rapid, and the cost is reduced, but you're losing that specificity. When you're looking at your antibody tests, it's not as good for the early stages of infection. And then your nucleic acid testing, we know those can be pooled, which is very advantageous, again, in the emergency department if you're trying to get your lab on board, if you're trying to get your operations people on board, seeing that you can do this kind of mass screening is very helpful, but it takes longer. And so if your operations people are saying, well, we don't want to increase the patient's length of stay just to get the result back, then this will be a little bit of a problem because you'll have to then hunt the patients down for notification. And we'll get into result notification later. As we were talking about, like on that spectrum, you have the patient selection component. Are you going to just test those who are diagnostic, right? And that's, I think, what most emergency physicians, giving a nod to really the community ED doc. So, at UC, we had the main academic hub, but we also had a community ED shop. And so I was just thinking of like the most community ED doc, we could get them on board with the first row, and then rows 2 and 3 were a little bit more difficult, right? So, the middle row, the targeted risk base, we base off of your sexual risk factors or injection drug use risk factors, IVDU. And then your bottom row is really what, we're aiming for. This is based off of national recommendations, and we'll go into that, and really what this group has done a lot of work on to really help to make this the norm now, hopefully. Staffing options, another big piece of this to consider is, who is doing this work. It could be a usual ED staff. You'll definitely need a lot of, buy-in, obviously. It's great if we can make this, again, part of regular clinical care. This isn't like a side project. This is part of the care when the patient comes into the emergency department. But the time constraints of existing demands always exist. Again, something we saw very much with COVID. You can have ED staff that works along with the providers, the APPs, residents, which is nice because you don't have those workflow interruptions when you're just working a shift. But then again, the physicians, APPs, residents, they think of this as a separate program, and then there's always the sustainability model, right? How are you going to fund these people? And we'll talk a little bit about that. And then, we know most hospitals, right, have some sort of health service staff, social worker, community health worker, case management. So you can also get some buy-in from them and see if they would be interested in helping you with the, screening, consenting, screening, testing, result notification, linkage to care piece, because this, can very much fit within their wheelhouse. So this is an example, as I said, I recently transitioned to university hospitals. So this is an example of basically what we were kind of proposing. We're starting a more robust HIV and hepatitis screening program this year. And so for HIV on the left, we were identifying based on sexual and injection drug use risk factors. We're going to do the combined antigen antibody testing. On the right, we were going to initially just recommend the hepatitis C testing in the birth cohort, so 1945 to 1965 birth year, and CDC risk factors. From there, we'll have patient navigators who will receive a list of all of these results, and they'll notify patients. And then the linkage to care piece, if you're positive, refer to HIV care. If you're HIV negative, we really want to build up our prevention arm, which is like a newer, with multiple FDA PrEP medications being approved. This is kind of a newer piece to it. And then for hepatitis C, we'll refer to our GI hepatologist. So with that, I'll transition to Dr. Masello to talk about kind of the next stages.
Thank you. Thanks so
Yeah,
much.
absolutely.
So, I like to play with this thing here, my little thing right here. So basically, depending on how you're going to set up testing, right, you have to decide how you're going to, talk to your patients about this, right? Because they're going to find out about it, especially in this era where all of their results are available all the time, and they'll have results faster than you have results when you go to see them again. And so basically, when you want to talk about this, you have to have a game plan up front about A, what your state allows, whether it's opt-out versus opt-in, okay? And then secondary to that, how you're going to handle when people have inevitable questions, right? And you have to have a little bit of a spiel, right? Not a robot spiel, but a spiel that you're passionate about and can make it work, right? So basically, when we rolled this out in South Carolina, when we weren't doing this at all, right? And so trying to push this out there because nobody thinks HIV is in South Carolina, even though it has 38% of the population and has 51% of the new infections, right? It's there. So when we talk about it to the practitioners and the PAs and the physicians, it says, okay, look, if you're going to start testing for HIV, if you think the patient is sick, right, they have thrush, they have some sort of AIDS-defining illness, just test the patient, right? We don't need protocolized testing to go on that. So if it's part of your clinical care, do it. However, to explain the generalized screening, you're going to have to bring in some bigger guns, right? And so you're going to have to talk about the CDC, talk about the United States Preventive Services Task Force, and say, look, I'm not making a judgment about your life choices. I'm testing everybody that comes into the emergency department. Because inevitably, you're going to have some people that say, I don't do drugs, or I'm not this, or I'm not that. Why did you test me? Well, we tested you because the CDC recommends that we test you, right? And you have to go into it and say, look, this is not a judgment of your life choices. We're just testing everybody. And this goes along to breaking up some of the stigma, right? This is the reason why there's stigma that still exists. Is because everybody thinks of these diseases still being in those subpopulations. IV drug use, sex worker, right? It's not, but it is actually otherwise everywhere. And so that's how you explain sort of some of the testing process behind it, right? And then you basically say, this isn't a death sentence, this isn't anything, we can help cure you, we can surround you with services, right? When we talk about who pays for this process, because when you try to bring this to your hospital leadership, they're going to be like, okay, sounds great. Who's going to pay for this, right? Are you really going to ask us to ramp up testing in people that are unfunded, right? And then we're going to eat that cost? Yeah, no thanks, right? Especially since if your community shop doesn't have a very robust treatment center or the ability to sort of bill for some of those medications to cover the testing costs like some of the FHQCs do, then you really have to try to justify who's going to pay for this. So, thankfully, there are other places that you can utilize to help you support this ramp-up process, right? So there's industry-sponsored funding from Focus that comes directly from an offshoot of Gilead as part of their philanthropic arm, right? And that's the Frontiers of Communities in the U.S. And so they have the ability to provide funding both for your time and for you to build up team. They don't like to pay for tests. They like to pay for team members. So the other part of this argument is, who else do you have to partner with that can help pay for the actual testing? So I know what I had to leverage was I went to my local public health departments and I said, okay, what's your testing like? And they said, yeah, we have this many tests. Okay, what if I told you I could give you X number of tests, which is double what you already do, okay? And it cost you this much, right? They said, oh my God, yes, and now throwing money at me, right? Because the benefit of you guys working in the emergency department is that your overhead costs are cooked in, okay? They're already there. And adding testing onto your line in your lab or in your emergency department is a very small charge versus them getting funding to actually build up to pay for the lab, to pay for the testing, to pay for everything there. You work in an emergency department, you already have a lab which is running 24 hours a day. So adding on testing in yours is always going to be cheaper. They told me I'm 60% cheaper than them trying to pay an FHQC to do the same amount of testing. I'm open 24 hours, and I have more robust linkage to care. So they love testing us, using us to test, okay? What we do then is you have to set up then a parallel process to be able to say, okay, if I'm going to do this testing, how am I going to stratify the testing so it goes to the bucket A, where government's going to pay for it, or bucket B, where you try to send it to private insurance? And we're going to talk about that. When you want to talk about setting up generalized screening, if you are in a state that is opt-out, you're going to have to create some sort of opt-out language, and you're going to have to show that language to patients. Luckily for me, this was already done before I got there. So thankfully, somebody was thinking about this way before I got there. In our general consent for treatment, okay? In the second paragraph, bam, it's right there and underlined. You're coming into the emergency department, we may test you for diseases of public health importance, including HIV, hepatitis C, right there. And then below that it says, if you get stuck, we're definitely going to test you. So it doesn't even say, we can test you. It says, if you get stuck, we are going to test you. The sideline of this is to say, you have to know your state law, okay, around this, whether you're an opt-out or an opt-in state, okay? Follow those guidelines and then work with your legal team to make this otherwise work, okay? As part of my testing protocol, we also have a way where when you sign it, I get an epic ding so I can actually rapidly pull a report to show whether or not they have signed their consent or somebody else signed their consent. Because that's the big part about that. If you want to use this as straight up opt-out language, you have to have ammunition to say, you read it, you didn't opt out. Just to put that out there, because I don't want to get, the Kiminustapulu law firm coming at me, okay? So that's the other part about this.
The reality there is they're not really consenting because they're signing it. I have no problem with this. I'm actually struggling to change our consent to this language, but
Correct.
it's basically not really.
Yeah,
You're
I'm
not
not sure.
notifying patients.
I'm not sure that counts as opt-out.
The other side of that is that we're going to talk about that. So there's different ways to get at this. So this is the other side of this. So this is the way to do this. So the different way is to be triage-based to make sure that the opt-out language is forward front. And I have better pictures of this later out. But the way that this works is, depending if you're at first or second triage, whether it's generated by BPA or whether or not you go through first triage, they're asking you to say, we consider it standard of care to provide HIV testing and hepatitis C testing if you've never had it. Silence. Then they say yes, no, whatever, and then you go from there, and then the testing is automatically ordered, okay? And we're going to talk about this. The other way to go at this is otherwise episode-based, where the patient presents to the ED, you make sure their consent is signed. If it's not signed, nothing to do here. They are signed. They were treated. There's blood in the lab. You have either your physicians order it at the time, and then they talk to the patient saying, hey, I think you have HIV. We need to talk about this. Or generate a list of who had blood in the lab, who had a consent signed, and then start to do ordering tests from there, and you're just confirming that the consent was otherwise signed. Okay, so different ways to talk about it, and we'll talk about nitty-gritty on this as well. So the other thing that you're going to have to build in here is some sort of mechanism to support the physicians who test to make sure that they're not just doing a fire and forget and that there's no support behind them, or that you're not going to negatively disrupt workflow in the emergency department. If your operations director thinks that this is going to negatively affect workflow, don't even bother bringing it up, okay? Because if it makes them wait in the emergency department 15 minutes longer, they're going to kibosh it. So what you have to do is set up ways here to make sure that you have a robust system to find these patients after they leave, okay? So this is part of the thing is having that as an ability to say, you can send the test, put in a console for my team to follow them up, and let them go, and we will follow them. Then have the backside of that where when you link that patient, send them a note through Epic saying, hey, remember that patient you ordered and you sent out? We got them into care. They're already in their first appointment, right? So then they know stuff is going on behind the scenes here where there's some sort of big brother process that's supporting them, that they can order testing and the patient's going to get linked and they didn't have to do anything. You have to make it easy, okay? Once you make it easy, everybody otherwise wants to do it. Basically, operations result notification, basically negative is easy, right? No news is good news. If there's otherwise positive, right, then you have to work on workflow. Oh, wait, am I supposed to go on this or is this you? Okay, sorry. Basically, who's responsible for the next results, right? Options is you have to figure out who is going to notify the patient and how you're going to link them to care, right? And so when you have those positives, sometimes you'll already have this. Some of your nurses may already be doing callbacks for positive blood cultures. So do you want to add this onto their ability to call patients back and link them to care? Perfect. You may already have those operational pieces that are otherwise in there. Otherwise, you're going to have to either bring in your social workers, hire new RNs through your focus funding that may otherwise pay for those people, or link them to your health department with disease investigator services or whatever mechanisms you have in there. Again, part of your state law may have ways that you can mandate people to get treatment based on going through their health department, depending on which state you live in, okay? I'm going to turn it back over to Kieran at this point, right?
So we covered a lot of this in the different discussion, but, other common questions you're likely going to get, who's responsible for the testing, and just defining who that team is. Is it going to be the discharge nurses that you have? Is it going to be a team that you hire? Is it going to be something hospital-based? Will you transition? The discharge nurses is a really good way to start before you can kind of build up to your own team. And then who's gonna tell the patient that they're positive? Because if the results don't come back while they're in the emergency department, then you need that team to be able to call them or, get a hold of the patient to let them know. But these are all the questions that, you have to definitely think about and kind of work through before you start to pitch it. And then what does that linkage to care process look like? So if the patient does test positive, we will get them into X infectious disease clinic, and we've already spoken to, these infectious disease physicians or these internal medicine physicians or these hepatologists, and they know that we're gonna be testing, they know we're gonna have this pipeline of patients from the emergency department, so then those clinics aren't saying, well, why are all these patients coming into the ED, and, why are you asking for 48-hour turnaround appointment times and things like that. So it's a lot of collaborations with those kind of downstream linkage to care providers. And then you in the emergency department may not get this question as much, just due to the nature of our environment, but, reinforcing that if you are positive, and this is also really important too for your patients who did test positive, if you are able to re-engage them in the ED, but, what is the goal of treatment? That you can be undetectable for HIV, that you can be cured for hepatitis C, and that is the ultimate goal. That is where we want to get you. That is that last, column in both of the care cascades. So now we weren't able to pull up Epic itself because of all kinds of firewalls, whatever, even in a test environment. So we have some screenshots that show how we implemented this in the EHR to give kind of put some visuals behind it and show some examples. If you're interested in, in starting this at your
Sure,
place.
sure. So when I talk about this, it's kind of a one-size-fits-most, and you're going to have to figure out what's going to work with your workflow, right? So this is part of the triage-based protocol that's up. Now, I am working towards this. I do not have this at my shop yet. My partner/friend, Greg Hall, and down in Charleston, this is what he has built, and I'm stealing this, and I'm going to try to implement it in my own ED. But you got to get buy-in from nursing to make this work. So basically what happens here is there's different. Triage 1, Triage 2. Most of you probably have some sort of 2-level triage. So this is Triage 1. So as they come through, and presumably you could do this when you're not shouting it across the room, hey, we offer HIV test, and stuff like that. Again, breaking down stigma. At some point, I wish we could just talk about it openly, so it's not a scarlet letter A on everybody. But basically, at Triage 1, they have this process set up where you can actually ask the same question. We consider it standard of care to offer HIV and hepatitis C testing as part of your care today, and we'll pay for it if you can't pay for it. Silence. They don't say anything. Great. You click the yes button, and it automatically orders the testing, okay? Then they just click in, boom, done, sent, test is gone, and the patient is in the waiting room, and blood is automatically drawn, and you're off and running, okay? If, however, they get through Triage 1 and they haven't answered that question, then nursing gets a BPA, okay? And so if they hit Triage 2, it hits them over the head and says, okay, if they've never had an HIV test in their EHR, then they get this BPA, all right? Never had an HIV, never had a hepatitis C test, they get this one. Again, please prompt, ask this question. It's the same stuff here. Our hospital standard of care is to include this testing. It'll be part of your lab work unless you tell us otherwise. They don't say anything. If they decline, you hit it. If they don't decline, it's auto-checked. So as soon as they click out of there and they don't decline, boom, it's sent, test is running.
So just to pause too, so BPA, and most people here have Epic, but it's the best practice advisory. And another thing that, when I was going through this, I kind of learned that you can have BPAs that are like the hard stop versus the soft stop. So, can I just hit cancel and get out of it? Or do I, does the RN or whoever's doing triage, do they have to check a box before they can go on? And it really just depends on the culture of your shop. Like they were okay with a hard stop, but in your maybe more hesitant or conservative or whatever word you want to use, they may say it's a soft stop. So then you don't know the fidelity of, of how this is actually going to be filled out.
Yeah, that's a great point. Yeah, and so the EHR is based in here too. So if they've had an HCV test, then it just brings up the HIV, and vice versa. If they've had an HIV test in the past year, it just brings up the HCV. Okay, so this is the way to kind of work within your shop to make sure, and then you can have the EHR actually bring in when their last test was. Okay, and so to bring in what those results are. Okay.
Those are the only options for them, or what if patients
Sorry.
comatose or agitated or altered?
That's the hard versus soft stop. So at that point, you would probably click either declined or whatever. For this one, it's actually a soft stop, because you can hit cancel and get it out. So it depends on how you build it, right?
If you cancel, does it force you to choose why you canceled it?
I don't.
You can design it that way. Usually, no.
Yeah.
You'll just can't. I mean,
I was just curious
You can
Please.
try that, but I'm sure your nursing staff.
Yeah, this one doesn't. It just kind of clicks over and then just leaves it in space.
You're trying to track why tests aren't happening, you kind of want to know, are they just pushing decline? I mean,
Yeah.
it's into the details.
It's the research versus operational give and take of our lives.
The issue with that too is that the more you build into this on nursing, the more buy-in you're going to have, and the more they're going to hate you.
Yeah.
So, like, because triage is already bloated as it is.
So this is important. Let me say something about opt-out testing in general right now. So first of all, opt-out testing, remember the goal of HHS right now is to really move this to a non-stigmatized environment where this looks like other testing. So look at your state laws, make sure you're following your state laws. We've done a lot of work with the state DOH to make sure we're following laws. We have something similar to your general medical consent form, right? We also have signage. And signage
Yes.
has been looked at by a lot of attorneys. The attorneys like the signage. It's in the rooms. It's in every room. In trauma days, it's there. Maybe the patient's blind. Maybe the patient didn't read the form. Maybe they didn't see the sign. Here's the key part and the reason why these are okay to start with, but the quieter you can make these BPAs, the better. Because this, in a way, is stigma.
Yes.
And we don't ask the patient if they want a creatinine today. And we don't say our hospital standard of care is ordered a CBC that includes these tests. So I understand look, you're changing a culture. It's implementation science. I get all those pieces. But just understand in that, try to push in compliance with law what opt-out testing is the best you can without adding steps that look different from everything else that's also opt-out testing, which is what we do for our patients, for everything else in the hospital and the ER.
Correct. And
The next version of Epic will have the ability to silent EPAs.
Hmm.
So instead of having, and this is something that we struggle with in our shop, instead of having this physical thing that interrupts flow, you'll actually be able to have it going on in the background. So it'll actually face the warrior and just have
And my chair actually likes that because our state laws are very supportive for us to do testing in South Carolina. You wouldn't think so, but it is actually for diseases of public health importance like this, like for syphilis and things like this. It's actually quite supportive and actually covers that. So on the other side of that then is,
One other thing though,
yeah.
if you're in a state that does require opt-in consent, it actually has to be the clinician doing it, not the RN. That's surprisingly Massachusetts, our laws are incredibly challenging to actually test people for HIV, and we can't have the nurse doing it because we actually need consent, not just permission. And so that's a distinction that's made in some states.
so that's why we make it up as you got to follow your state law to make sure otherwise goes there. And also the reporting requirements as well. So the reporting requirements in South Carolina is that I report to my public health department. I do not actually have to report to the patient. That is not part of my state law. It's state law that I have to report only to my health department. We do sort of post-test counseling and stuff like that as part of my linkage care coordinators, as part of me. And that's the other part of this is that you're going to have to make yourself available when this otherwise rolls out. So if anybody finds one, right, find somebody, right, that you're online, they send me a telematic message, they send me a text message, I'm like, hey, I'm calling, and try to link them almost as fast as you possibly can so that, again, that support is there so that I feel supported. Just to put this in perspective, my generalized testing is around 0.2, closer to 0.3%. When the residents send tests or the physicians send tests, we're talking about over 2 to 3% positivity rate, right? So then they start smelling it, right, as you were, and saying, oh, there's something odd about this cold, there's something odd about this fever, and it's not like we're finding people with thrush, we're finding people earlier in the disease because they're already thinking about it. And that's the other part about this is that once you set up a shop, especially some of these places have residencies, right, then it becomes in their forefront that as they go to their next place where they work, hey, we should be doing this. I did this at my shop. Why aren't we doing this here, right? So this is my episode base. So this is currently what I have right here. And then basically what I ended up doing is I tried to make this as easy as possible, right? So this is blood in the lab, signed consent, right age group, no HIV or hepatitis C testing in the past year. Generate this report every morning, and then my linkage care coordinators go to work, trying to put in the orders on the back end, right? And then this is the only part that you have to figure out whether or not you're going to have your bucket testing go to one bucket, and you're going to adjudicate it afterwards of where it's going to go to government if you have other funding, or straight up to their insurance, or you're going to do it up front. So what I had to do is, based on my places, I had to set up 2 separate parallel orders where they have different landing points for where they go to the billing, whether it's going to go towards their insurance or whether it's going to go towards my government funding. Okay?
Does your shop allow add-on?
It does. This is all add-on. So that's the point, is that all these people had blood work, right, that was done for whatever, okay? They had a signed consent. They had blood in the lab that I could use for HIV and hepatitis C testing, and then I can add it on.
So this is going to depend a lot on your system.
It does.
In my system, there's one of the hospitals allows it and the other 6 don't.
That's interesting. So again, talking about this, and especially when you're starting out a different hospital, the other thing you have to figure out too is what testing is your lab using, right? So not all labs test HIV on the same tubes. It could be on pink, it could be on green, it could be on yellow. So when I tried to move this down to Columbia, they do all their HIV and hepatitis C testing on yellow tops, which is on basically HIV and thyroids. So unless the patient has thyroids, this report didn't work. And then the lab was like, I thought we were all one happy system. No. Our lab only does it on this. So again, you bring up a great point. You're going to have partners in your lab and tell them that this is going to ramp up testing and possibly carve out some of that funding to pay for tech time. That will get you an ally in the lab very, very, very fast. If you can carve out some amount of funding to pay for tech time, your hospital will love that. You're also going to have to talk about when that testing is going to add it onto the line, first shift, second shift, third shift, right? And what they do with positive results afterwards. Most of the time what it'll be is first shift, great, we're on it. Second shift gets really busy, and at some point during second shift, they're going to be like, I'm not doing these add-on tests anymore. I'm going to leave it for first shift the next morning. Third shift, straight out. They ain't going to do it. They're always at the lowest staff, so don't even count on it. So yes, you're open 24 hours, but they're just going to batch it the next day, which is why you have to have a more robust system to follow these people when they go out.
Could you go back to that billing thing, that differential billing?
Yeah, sorry.
Just a-
So when Epic creates an order, just to kind of go in the weeds about this, and that's why you're here, everything that you have in Epic is made for basically charging, okay? That's all Epic is basically a basic, huge billing sort of program, right? The thing that sucks about Epic is that everything is added on and nothing is ever taken away. So anytime they add on an order, right, whatever it is, that order links to a certain vendor product with a certain process and a certain billing code that routes that charge to either the patient or another client submitter account. I know this is getting really into it, but what you have to do then is create a shadow order that mimics everything the exact normal way for clinical charges, but routes to a different client submitter account that's a dead-end whatever client thing that you have to then have reconcile.
I was just asking, like, so is
Yeah.
that what you do for Hep C?
That does. I do this both for, so there's Hep C and HIV, so they're both in there for both.
So do any of the patients get billed for Hep C or HIV?
It depends up front whether you're ordering it, right? And so what happens then is you have to have another level of another level of oversight. So what happens is that I send testing up front to say this goes to my grant submitters and we pay for it, okay? Over here, this goes to insurance first. If insurance denies it, we reconcile that, but that can be sometimes 2 and 3 months later that I find that out, and then I can move it over,
I got it.
okay?
You bill everyone's insurance, and then if it doesn't go through.
You can set it up that way, but it's hard. I have the ordering physician make the decision about whether or not they want me to pay for it through the grant funding, or not grant funding, excuse me, through state funding or otherwise funding versus trying to send it to their insurance. There's different ways to make this work. There are other shops that do that where they send it, like MUSC, they send it here, and basically every test goes to their sort of client submitter account, and then they adjudicate saying they have Medicare, they have Medicaid, it should pay for it, and they move it.
Do you have any data on how many, this has been our elusive goal for years now, any data on how many HIV tests get reimbursed by insurance?
I can tell you right now, for our Blue Cross Blue Shield, easily 98%. Especially if they're in the birth cohort, absolutely, not even a question.
All of ours are bundled payments. We audited this one time, and we found almost all of the patients that we found had HIV tests were bundled payments. We didn't get a lick of that. It was kind of recouped on the back end. The insurance saw it, but they're like, we're going to give you $75 for this visit, no matter what happens.
Most of them have it listed in there as far as something that, at least down in South where I am, where Blue Cross Blue Shield and stuff is there, yes. Medicare and Medicaid should easily pay for it as well. This is clearly covered by their guidelines and everything else like that.
Everyone in our shop is Medicaid managed care.
Okay.
It brings you back to the bundled payments. Anyway, okay, you're doing great.
Like I said, we're just kind of going on. Like you said, there's nitty-gritty in here, so I didn't know exactly how much nitty-gritty you want to get into this, but this is sort of workflow that we've had to come up with. This is the way they wanted me to make the workflow, was go from here, insurance. If it's not insurance, then send it here. The other side of this is you have to set up with your Epic on who's going to get these results. So we inserted my Linkage to Care navigators and me that every hepatitis C, every HIV test that is sent through the department, I get it. So my inbox is full with 300 a day, okay? And that's just something that I take on and my Linkage to Care navigators take on. The last part of this is basically, again, the notification and Linkage to Care part, right? So I made this otherwise where you can have it where you can fire and forget. right? And it came up with a little catchy line here, the iLink team, because they link everybody to HIV and hepatitis C care, and it's all flowery and stuff like that. And then basically what I made it is that there's a generalized a consult order in Epic, right, that allows them to otherwise consult my team whether or not they have the results back. So if you click into this order, it says, cool, did you send testing and they're unknown? Yes. Did you send testing and they're known, or are they a known positive, relinkage to care? Just a couple choices. They click that, go, and then you automatically get a list every day. Here's your consults of people, and then we follow up on those people. So there's multiple levels because Epic is not perfect. Even of all the testing I sent for the results, I do not always have a one-to-one of when I sent the test and I get the result back. So you have to have multiple ways to capture these people.
Yeah, so another way that we do this in our system is rather than making the provider or member to actually order that linkage, we just have a list from the lab every day that goes to our linkage navigators, and they just scroll through it and contact them.
That's what I'm saying. I still have that. Like every test that's sent in positive or negative comes to us, and so that we can make sure that we follow up on those people. But this is just another level in case A, they didn't send the testing and it's a known positive, and they talk to the patient, they want to make sure they're linked to care, or B, they've sent the test and it gives us another notification that they've sent this test and it's out there. Okay, it's just multiple levels of support to otherwise make this work. All right, and so that's the order test, and then I'm going to turn it over to Jason again. Sorry, I took way too much time.
We got plenty of time. When I listen to this, I just think like, wow, it's a lot of information and a lot of detail, right? No, and it's good information, but it's a lot of detail. And I've spent the last number of months, maybe a couple of years, thinking about like, we've been doing this for a long time. Like, what's the best approach, right? And when I see your experience and I hear about others' experiences, I'm like, everybody has their own approach, right? And there's really doesn't seem like there's much of a standardization. I mean, we're moving in that direction, but every place is a little bit unique, right? One of the things that we wanted to share was this stuff, and many of you know about this. Actually, some of you here have been part of these projects, but we developed a risk prediction tool years ago to actually incorporate into our EHR and to do targeted screening as one option. We published these results last summer as part of the HIV tested trial, where we compared two forms of targeted screening to non-targeted screening, and ultimately found relative equipoise among the strategies. There's some differences there. You do more testing with non-targeted testing, you find about the same numbers of positives across all three strategies and so forth. And it's really, I think this, in context of everything that's been said, this really has me thinking about what's the best approach. And I've really come like full circle. It's not, I'm a data person. I will do what the data show. I think we have to get to a place when we talking about destigmatizing and breaking down barriers to integration into care. I think you have to move away from something like this, honestly. Although I think there's utility in this. It's done for HIV risk score. Some of you might have known, and this is what it looked like in our EHR, in our Epic, where we actually had nurses screening patients and toggling a few of these questions, and it would quantify the patient's risk, and that would drive test offering. And then the test offering looks very similar. It's a single BPA. This is based on risk profiling. This is non-targeted screening. The notion being, though, is that we're going to perform an HIV test on you today unless you don't want it, right? It's notification, right? And a patient can decline it or not, and it's an auto entry. It's sort of an auto order. But I'm deviating a little bit from what I was going to say, because listening to the conversation, I'm really fascinated by the fact that here we are in 2022, right? How many decades later, right? It feels like, right? I've been doing this work since the mid-90s, screening. A lot of us in this room have been doing this work for a long time, have contributed substantively to this narrative, and yet here we are, right? And we're still like trying to wrap our heads around what's the best way to integrate into care, what's the best way to screen, what's the best way to offer consent. Obviously, there's constraints around law, I guess, and then what's the best way to bill or fund these programs. And yet, here we are today still sort of contemplating all of this. And it strikes me that we're right kind of poised to now to take the next step in terms of synthesizing how we think about this. That's sort of my sense about this as a general comment. I think last slide, right, this is this notion, and I want to just speak to this idea, because our approach which is different from everyone else's approach, it seems, is that with HIV screening, we went to the lab years ago. If it's not in the context of a research project, of a grant-funded scientific project, we went to our institution and said, it's just part of standard of care. We're going to do screening. They don't tell us how we do it or how many we do, and if the patient gets tested, it's built in. It's cooked into their billing process. And our reimbursement isn't great, but I'm at Denver Health, where our reimbursement broadly isn't great. But the fact is that my institution has done sort of mathematical kind of calculations around this and says it's fine to continue, even if we have a large non-reimbursed rate. So I think the charges versus what's reimbursed and so forth all play into that equation, essentially. And then the same thing, and that's driven, honestly, as you all know, by the USPSTF grade recommendations and Medicare funding, but the same thing holds true for hepatitis C, I think. And we're moving in that direction in terms of doing that as well. So I don't think we've all worked in a place where grant funding, funds from the state health department, funds from Gilead, funds from research projects help to support these projects, but we have to move way beyond that, right? We have to move to a sustainable, right, model that is baked into clinical care. And the one caveat, and I'll leave it at this, and then I'll just open it up for questions, comments, but right, preventative interventions like HIV and hepatitis C screening is not, classically an emergency department kind of thing. It's parallel. It's something that's been inserted into emergency care. It's not why the patient's there necessarily, and so we have to continue to work and find ways to integrate it in a way that, right, destigmatizes and makes it sort of part of standard of care in that way. So I'll stop there. These are emails. I'd love to hear other people's thoughts on this topic, though, because and back to what I was saying about where we are right now and how does it all come together in the next 5 years or less. Ethan, good to see you, man.
One of the things about sustainability,
Yeah.
these programs can make money, actually substantial amounts of money. So if you are at a site, if you are at a place that qualifies for 340B funding,
Yep.
so you take care of a disproportionate number of Medicaid patients, if you can link these patients into care and get them on treatment, particularly your HCV patients, the amount of money is substantial.
Yeah.
The hospital gets money back as these medications are prescribed. That's what pays for heart and iron. We don't have any.
Yeah.
And
Now the 340B and FC, but it comes back to the core addiction stuff.
Now,
And-
340B may go away and then it's all gone, but it is one, it is something that makes it attractive to the hospital because it can make money.
This is actually all driven by our pharmacy. Our pharmacist actually approached me and said, we need to do more HCV screening, we're not doing enough.
Yeah,
yeah.
I hear you.
We have to agree to do away with consent. I think that has to be, as a group, we have to say, this is important, we want to do this, and consent is still getting in the way. None of us agree, it's time. I really do believe that. It sounds radical, but I think we need to be the ones pushing for that.
Well,
It's very hard, because even in our state, I tried to get rid of, to make it just general consent. I found a legislature that wanted to do it, and it just got shot down by someone, like, they won't say, but they're just like, there's not a lot of, like, feel for this. And I'm like, well, we just want to switch it from this opt-out consent to just general hospital consent, like we do every other test we do.
Right.
And it still didn't.
And again, it's partially because, again, there's stigma associated with that, right? They don't think it's there. They don't think it's a problem they have to deal with. They don't want to field those calls from angry voters who say, blah, 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 right? So,
I want to stay with the jurisdictions in the 53 ending HIV epidemic jurisdiction. I think that's the way to reapproach it now, right? Because you've got a lot of federal ammo there that basically says you guys need to get right by you're in a top. I don't know if you are. I don't know what state you're in.
Hey, Ohio.
Yeah.
Yeah, there's no question, but it still didn't, it's gotta go through the state
And I
legislature.
wonder if anti-group, if we should look at the states that still have opt-in, the ones that are left over, and do something about that.
But it's not even about opt in, opt out. Like, to me, that's
Agreed.
irrelevant. It's talking to the patient and trying, I just feel like it's getting in the way. And it's always,
and I think
This
getting,
is just part of, it's like a mammogram. I
Yeah.
mean, it's a goal, yeah.
When-
feel like
Here
we're
it is,
gonna
it's like a CDC.
It's a CDC,
That's right.
yeah.
That's right.
I think to move that needle, like, because we had the same conversation around opt-in and opt-out years ago.
Yeah.
I went to the state health. the state, state legislature testified, and then they changed the law in our state. So
And I did the same thing in
Yeah.
California and moved to opt out.
you know, the same sort of thing could be driven by the group to say like, okay, we're gonna try to change it.
But did you
Well-
try to move it to general consent
No,
instead of
Well,
opt-out?
no, opt out, that was a big win at the time.
Sure.
Well-
Sure.
Yeah.
2005, the CDC guidelines.
I was gonna say the CDC,
They
yeah.
were ahead of the states.
Yeah.
And that felt like, okay, we could just get to opt out and problem solved, but it's not, it actually complicates it, it probably did.
It was positive and negative, right?
Yeah.
It did a disservice because now we're talking about opt-out, opt-in, and it created this lens at consent.
Standard, which
Yeah.
is based on nothing.
100%.
I
I 100% agree
I
with you,
think
Doug.
data. I think data
That's
drives that as well, right? To show that this is still a problem. There are still positives out there that we find every day in emergency departments, and that this is a local problem that you need to test. And I'll say, of the calls that I field where people say I didn't read that on my consent or anything, it's always the negatives. Anybody that's positive that you find, it's always like, thank you for testing me. Oh my God, what's the next step?
So let me say about that too, that's actually very important. So we test about 1,200 people a month, right? Been doing it for 8 years or so now. We get about 2 complaints per year, and our, corporate compliance department, claim department basically said, you guys actually, of all the services, have like the lowest complaint rate basically, because I always get worked up when I see one, like, I'm like, oh, here's a work compliance lady again.
Right.
Because I did this illegal test with
Yeah.
somebody.
Right, right.
And I met with her, and she's like, oh, no, I'm not worried about you guys at all. It's like 2 a year out of the thousands that you
Yeah.
do.
And mine come in waves. I get maybe sometimes 2 weeks, sometimes none for months at a time, and then it comes out. And if I just call them up and talk to them and say like, hey, I want to talk to you about this, right? And when you actually sit and you talk to the patient about the scope of the problem and say, hey, I don't know if you know this, but we find 100 patients a year for HIV and like 600 hepatitis C's, and like, oh my God, I didn't realize this was such a big problem. And they're like, yes, it is. Well, then that's awesome. It sounds like a great program. Keep going, right? It's just, they feel sometimes that it's like hidden in the background and that you're doing testing on them for, I'm not a drug user. I get it. I know you're not a drug
We
user.
have a lot of these standardization programs.
Right.
There's,
Just to put it in perspective, in my local area, the main treatment for HIV is in an unmarked building. Down the street from my hospital, it's called 8 Upstate. They don't put the address out and don't put a name on the side of the building because people were sitting out front taking pictures of people going in and out for treatment. That's how bad the stigma is in South Carolina. That's what we have to otherwise break down. That's what we have to break down and stuff like that. And so when people get tested as part of their routine care, yes, you got tested and you're negative, congratulations. Well done.
there's
Now
ano-
we don't have to test you forever.
hey, Phil, there's another session here.
Yeah.
We gotta go.
Sorry, we gotta.
Thank you, everybody.
Thanks.